this is Chapter 12, Lecture Video, Part 2. Chapter 12 is Gender, Sexual, and Sexual Orientation Differences. There is one part that I probably should have added to the previous lecture video that I wanted to cover before we talk about sexual orientation, and that is treatment implications for gender differences. So most men and women are treated in mixed gender groups that do not provide specialized programs. Services that are specialized for men are 25%, for women 31%, and pregnant or parenting women is 12%. Women actually have a less chance of recovery and staying recovered due to history of trauma and violence, higher prevalence of co-occurring disorders, especially mood, anxiety, and eating disorders, and different roles, such as caretaking roles with children, partners, and others. And some questions to kind of put out there, and I'll give you some feedback on them. First one is, do you think having women paired with female counselors is important? Actually, no. A study of this reported that women wanted a counselor who respected them. It didn't matter what gender they were. Do you think that sexual harassment in treatment is an issue? Yes, it is. Over half of respondents in one study in 1996 reported sexual harassment by male counselors, even though they were not asked about this in the interview. And the last question, should programs for women promote abstinence or control drinking? A Women's Place started with abstinence and moved to choice. What do we do? What do we got for men? Men, expectations that men are independent, self-sufficient, stoic, and competitive. They report experiencing shame, violence, trauma, sexual performance issues, family issues like custody, support, and relationship with partners and children. We usually talk about the impact of trauma on women, but men do experience trauma as well. So that's something to keep in mind when we're talking about gender differences. So both males and females could actually benefit from trauma-informed care. Trauma-informed care focuses on the impact of trauma, viewing symptoms of trauma as healthy and adaptive, knowing that we can recover from it. It's strengths-based. Change from what is wrong with you to what has worked for you. The second benefit is signs of trauma in clients and females and staff. Third, changing policies and procedures and strategies accordingly. And lastly, taking steps to resist re-traumatization. This involves the transformation of an entire organization away from labeling, reliance on medication to control behaviors, and some forms of behavior management. Workplace stress has to be reduced, and there has to be safety at every level of the organization. So those are some things to kind of keep in mind. Let's take a step now and move towards sexual orientation in regards to addiction. So I want you to think about these myths about gay females on the bottom of page 495, and I'm going to read them out loud for you here. The myths about gay females are that they hate men, turned gay after a bad experience with men, can be made straight with treatment, would prefer to be straight. One is the man, one is the woman. Not everyone has that. They have AIDS. Their children turn out gay. So these are pretty significant statements being said about gay females. And it's unfortunate because, those are some pretty harmful words and some harmful things that a person could take in, and it might make them feel pretty crappy about themselves. And a fact is that, gay females actually have lower rates of HIV than gay men or straight men or women, unless they are injecting drugs. Some myths about gay men is that they choose to be gay and that gay men molest children, but that these myths are not the case. And we have to be careful when we're working with people in the LGBT communities, because if we are believing these myths, it's going to show when we're working with our population. So if you have issues or you have stereotypes, you need to work and address them before you work with someone, or be mindful of it so that you can, try to move past it. There are a lot of risk factors for substance abuse with LGBT communities, and some are slightly different than some of the risk factors that we've gone over in several other chapters. So I'm going to review those for you. First one is family rejection and victimization. This is associated with shame about identity and hiding their identity from their families. Internalized homophobia. Sometimes we have self-hate because we don't like the person that we are. Suicide attempts. LGBT community 2 to 3 times more likely than straight youth and higher for adults too. Depression. Drug use. Higher rates of smoking cigarettes and use of other addictive substances. Unprotected sex. HIV, STDs. Rejection by peers. Fundamentalist upbringing. Maybe the way they were brought up. Physical attack and murder, especially for gay males, and homelessness for gay youth. Those are definitely a lot of risk factors that put them at a higher risk for using substances. Gay female substance abuse has not been studied much in research. There are more health clinics for gay women and gay AA groups, even in small cities, but most are in larger cities. For gay males, their experiences tend to be physical attack and murder, psychological trauma, attacks on playgrounds, bullying for younger adults, of course, internalized hatred, increased risk of suicide, and pushed out of their home. Some risks, particularly related to substance use itself, sex is associated with party drugs, so ecstasy, meth, other drugs like that. Alcohol and drugs like meth are a social lubricant. So much like alcohol for straight people, it's putting yourself out there so that you're more likely to interact or engage with other people, or maybe even to be able to talk with someone about sex if you are gay. Meth is linked with unprotected sex, resulting in HIV/AIDS. More than likely, straights do not be able to separate sex from substance use. And if they are using, they're at risk of not taking HIV medications as prescribed. They're more likely to have multiple partners. Time spent in gay bars, lots of drinking, use of meth, cocaine, or longer drinking spans over a lifetime. More likely than straight men to slow down drinking as they age. So they'll slowly mature out of it. Maybe because they're less likely to get into long-term partnerships and so are more likely to hang out in bars. And if one member of a gay couple is in recovery and the other isn't, breakup is more likely. So that's something, to be aware of, or a risk to be taken into consideration. So we've talked about several categories of risks. How can we prevent this? If it is possible still, facilitate connectedness to a family and let them identify who their family is. Adult caring, social supports, anti-bullying, safe places, gay-straight alliances, stuff like that. We have, more so we are learning about transgendered individuals, and this is kind of progressing and, something that we do need to be more aware of in regards to addiction. Something interesting that I actually learned from reading your textbook is that Native American tribes often refer to transgender people as two-spirited, which is sometimes seen as a separate sexual identity from transgender. So they have two spirits rather than one spirit. Transvestite people have gender identity as is same as biological sex, but they cross-dress. They are not gay, may prefer more current terms such as cross-dresser or drag. Transgender is divided between pre-op and post-op if they have operations to change their gender. Some risk factors for transgender people specifically is anxiety and depression due to social disapproval and stigmatization, highest of any sexual minority and assault and employment discrimination. 40% reported attempting suicide, and adults report fear of being attacked. We don't know much about substance use with transgender people, but there is a high incidence of HIV. And there are a few programs designed for transgender people. The text actually mentions one 8-bed program in Philadelphia called the Morris House. And there are some other tips for working with transgender individuals on page 502 in your textbook if you would like to read more on that. We have bisexual individuals. Bisexual is you don't have a preference. It could be male or female or both. More women than men are bi. Some African American gays say they are bi to avoid being looked down upon. Bi is less objectionable than gay to those who are homophobic. or may live as heterosexual, coming out may not be tolerable. So those are some things to kind of keep in mind too, that, you know, they have either for preference. Treatment issues for LGBT individuals. As you can imagine, most treatment programs are not focused on sexual minorities or their specific needs, except for private for-profit centers, but there are very few of those around. As a result, sometimes it's actually safer for clients not to disclose their identity. So if they don't come out and discuss it in groups or in treatment, it might be better off for them so that they don't have to worry about that stigmatization or bullying or different things like that. It's unfortunate that that has to happen or that that is happening. Again, that's subject to choice. If the person chooses to be open about it, then that's up to them. But they might be encouraged for their safety to not talk about it if it is predominantly a straight treatment facility or straight group. Some things that could help, you know, it's best to have someone on staff who is openly gay. It's essential to not use heterosexist language, adhere strictly to confidentiality, be aware of risk factors that we've talked about and typical experiences. Use consultation as needed. You know, being aware is the biggest thing that could help us in this field. And a focus on spirituality, with spirituality in the LGBT community, a lot of times spirituality, churches, religion, stuff like that kind of like frowns upon stuff like that. So that may be more of a trigger for someone in the LGBT community. Not in every case, but it could be a possibility. The message of many churches feeds gay shame. Those with childhood religious affiliation reported lower family acceptance. So depending on what the family's religious beliefs are, they may be less of approval of, you know, their family members. If families can be encouraged to affirm the child, teen, or youth, young adult, it can help with the feelings of rejection. And there are gay 12-step groups, but, you know, pickups can be a danger, although that is no different from what happens in most gay bars. So some things to kind of keep in mind and to help you become more culturally aware and more culturally sensitive of these things, especially when working with addiction, because, you know, there are definitely a lot more risk factors involved. All right, and that is the end of chapter 12. Thank you for watching.